Woo woo.
Yep. Okay, I can also project. That works too. Thank you so much, George, for your presentation. I loved it, and I'm so glad to have you here and to have Emory in support of all of this. Our next speaker is also a representative of Emory and the Center for Psychedelics and Spirituality, John Zarrabi. He is the Principal Investigator on a clinical trial establishing the safety and feasibility of Psilocybin-Assisted therapy combined with comprehensive palliative care support in demoralized cancer patients. He received his Bachelor of Arts from Brown University, a Doctor of Medicine from the Warren Alpert Medical School of Brown University, and performed his internal medicine residency and palliative medicine fellowship at the Icahn School of Medicine at Mount Sinai and a Sarnoff Research Fellowship at Harvard University. He currently is an Assistant Professor of Medicine and Associate Director for Outpatient Supportive Care within the Division of Palliative Medicine at Emory's University School of Medicine. His research addresses identifying biopsychosocial needs among the seriously ill, crafting aesthetic, spiritual, and meaning-centered interventions, developing best practices for art-based education in health professions, and studying the role of emerging therapeutics to treat complex suffering such as cannabinoids, ketamine, and classical psychedelics. Thank you so much. Welcome to the stage, Dr. Zarrabi.
Thank you for that bio. Can people hear me? Yeah? Great. So I have no financial disclosures, and the research that I'm going to present to you today is funded by the National Palliative Care Research Center in New York and Emory University. Yep. So just to start, just tons of gratitude, a lot of serendipity and magic had to really come together, as George just described, for all of this to come together. Did that go right? No. So, 2-year anniversary of our Center for Psychedelics and Spirituality. The Department of Psychiatry had to come together. The Department of Palliative Care, Spiritual Health, the Winship Cancer Institute. Maybe a decade or two, the Michael Carlos Museum at Emory had an exhibit about shamanism that brought together so many of the cast of characters that came together to create this. And finally, the USONA Institute, are things working? Yep. Too close, okay. All right. The USONA Institute provided the medication for this study. So the USONA Institute is based in Madison, Wisconsin. Chuck Raison, who's the director of spiritual health at Emory, actually lives in Wisconsin and is their main scientific advisor and director. So in this study, and I just realized we don't have a slide about this, we're using a psilocybin capsule. It's synthetic, it's 25 milligrams for people who are familiar with the Psilocybe cubensis mushroom. Depending on how much psilocybin is in the mushroom itself, that's anywhere from 3.5 to 5 grams of magic mushroom for someone using it in this study, oftentimes for the very first time. Some people have really strong opinions about synthetic psilocybin compared to the natural Psilocybe cubensis mushroom. What I do know is a sliver of history. So some of you know, and some of you may not know, that Albert Hofmann, who discovered LSD, also synthesized psilocybin from the Psilocybe cubensis mushroom that was brought to him over from Mexico, from actually Marina Sabina, and that was used in hervoladas. Then one day in the early 60s, they actually brought that capsule of psilocybin back to Mexico, back to Oaxaca. And she took the capsule and believed that the spirit was also in the capsule that was synthesized in Switzerland. So we are using the capsule that's synthesized in Wisconsin. So I'm a palliative care physician. I've taken care of thousands of people with serious life-changing illnesses, life-threatening illnesses, generally from diagnosis through end of life. I've been here for 7-ish years. I've had some patients for 7 years, and I've had some patients for 7 days. So I've followed people throughout the trajectory of their illnesses. And what I love about my job is the opportunity to provide early palliative care. So people Most of my patients are quite young, 20s through 50s. They still have to work because they have to keep their insurance to get their treatments. They have kids to raise, drive themselves to appointments. So when you think palliative care, I ask you to imagine just like anyone sitting in this audience instead of maybe someone on their deathbed, because that's really the population we're targeting in this specific clinical trial. Something else I love about our field is that many of you can imagine medicine is very hierarchical. In palliative care, that hierarchy is, I would say, much more flattened, where the opinions, the beliefs, the perspectives of chaplains or spiritual health clinicians, nurses, social workers, and psychologists, and the knowledge and wisdom that they bring to interpret the suffering of another person is as valid, if not more valid, than what a physician has to bring. People have been sick and dying since the beginning of our species. The modern hospice movement and palliative care movement, however, is the mid-20th century movement. Actually, the hospice and palliative care really emerged at the very same time that people were studying psychedelics for the very first time in the Western world. And these were, I would say, parallel and intersecting fields. Palliative care clinicians were writing the forewords of psychedelic books. Psychedelic books were edited by palliative care clinicians. And as you all know, in the 70s, psychedelics became Schedule I drugs. The research field died, whereas hospice and palliative medicine became a structured trade association, legitimate field of medicine. That Dame Cicely Saunders is the mother of our field, and she was a nurse, social worker, and a physician. She got training in all of these things, and she had a vision to help people who were suffering and in pain. And what she used, and what she was, I would say, just enchanted by, was the use of morphine, cocaine, and cannabis to help people who had a lot of pain and who were sick. Whereas the psychological world, and I would say that the kind of psychospiritual world, was more focused on fungi derivatives and LSD. And something she noticed, she spends a lot of time at the bedside speaking to patients. She actually ended up falling in love with one of her patients. You could read all about that in her memoirs. And something one of her patients said to her was, all of me is wrong. It's not just pain, it's not just depression, it's not just loneliness, like everything is falling apart. And she sketched in her notebook this idea that would become a foundational theory in pain medicine called the biopsychosocial model, and as well as palliative care, which we call total pain. And this is the intersection between the body, which you see on top, and the mind. I think many of us now take this for granted, but 100 years ago, this was pretty radical. And this is how we think of it today, this kind of synergistic crosstalk between social issues, psychological issues, spiritual issues, and physical issues that can really develop a confluence that make people feel like they're in distress, that they're trapped, and that they're suffering. And this is really the main thing that I see among my patients that's really hard to treat with pills, the sense of being trapped. And it's this sense of feeling almost like you're drowning, and this feeling like you want out, but there's no way out of it. Like, I don't want to be stuck on this ventilator forever. I don't want this tube in my belly forever. I don't want to be on chemo forever. I don't want to work forever so I can keep getting my chemo. These realities of what neoliberal capitalism has delivered to us in this society, as well as the realities of being able to live longer as a result of these miracles of modern medical treatment. We get to live longer in 2024 with whatever we have. And some people cope with it beautifully, and some people find it to be just an absolute terror day in and day out. And Tony Bossis, who's a palliative care psychologist, said that it's the spiritual, psychological, emotional, and existential despair that's really hard to reach. So there's this syndrome, and this is the main syndrome of our study, called demoralization. Demoralization is not a psychiatric diagnosis. You can't find it in any kind of diagnostic and statistical manual in psychiatry. However, I think if you ask any palliative clinician, or perhaps even a spiritual health clinician, they may tell you that this is perhaps the main clinical syndrome we're seeing in our patients. And this is this persistent inability to cope with whatever's been dealt to you. And it can look like hopelessness, helplessness, meaninglessness, this sense of subjective incompetence, which means, I want to be this person. I want to be the breadwinner of my family. I want to be able to drive. I want to feel independent. I want to have my libido back. And all of that is taken from me. And what's the point of life anymore if I have none of this left for me? And this is different than depression. So a hallmark of depression, you have to have two things, one of which is anhedonia. And anhedonia is the loss of pleasure. And I think this is an important distinction to make, just in general. And also so you can interpret this study that we did using psilocybin. So the example I often read is if you take a demoralized person who doesn't have depression and you give them, and they like cake, they like chocolate cake, and you give them a chocolate cake, they can savor it, they can enjoy it, they can say, this is a really delicious cake, but I still would rather be dead. There's no point in living. Whereas someone with classic major depressive disorder on the severe spectrum would not be able to, everything is kind of muted or blunted and you don't get that sense of pleasure. We can see demoralization in all of these kind of classic palliative care syndromes, ALS, advanced lung disease, dementia, heart failure, cystic fibrosis. The disease we're going to focus on today is cancer. And something I've noticed in my practice is, and this is, I think, again, part of the miracles of medicine, is people who maybe even a decade ago would have lived for weeks to months with certain diseases now live for months to years. Some people are in prolonged remission as a result of targeted treatments. Some people thrive and some people are falling apart. And we still haven't really been able to characterize what this syndrome is, of people who are ostensibly cured and better and yet can't go back to normal, what they would believe to be normal life. What was the trauma that hit you, or the sequence of traumas that hit you during your diagnosis, during your illness, from which you've ostensibly recovered, but you're still not better again. So one example of studying this was done by Brian Anderson in California. He studied demoralization in people who survived, I would say, the worst of the AIDS crisis in the 80s and 90s. So these were predominantly gay men who were age 50 and up, who had survivor guilt, hopelessness, meaninglessness, and again, they don't have a psychiatric diagnosis of depression or PTSD, but they still don't have this sense of well-being. And in this study, they received 25 milligrams of psilocybin with support, and this really informed the study going back to looking at the mind and body, back to the kind of the forefront of what palliative care was, to look at demoralization in cancer patients receiving early palliative care. So I'm going to talk a little bit about studying our patient population in Georgia who have demoralization and cancer, and then we're going to go into talking about our mushroom study. So about 40% of our patients at Emory have demoralization, and they have incurable cancers. That being said, almost 40% of people who have curable cancers or who have also been cured by their cancer also have this sense of hopelessness. And I think this is wild, right? Because in so much of our vernacular, it's you're a winner, you're a survivor, live strong, go run a marathon, go run a 5K. And yet so many people feel broken. Among that group, people with demoralization, 90% of them had physical symptoms like chronic pain. 90% met criteria for a psychiatric diagnosis, major depressive disorder. 50% were lonely. 80% had significant anxiety around death. And this, again, included people who were cured from their disease. 44% had PTSD, and 44% reported poor quality of life. And our group at Emory, a group at Harvard, a couple other places are really trying to quickly describe what this syndrome is. That's becoming more and more prevalent in our society, that still doesn't really have any strong acceptability in the medical community or the psychiatric community. So this brings us back to, when was this? The 1950s, when she was at the bedside hearing this, all of me is wrong. And I hope that some of this data can kind of give some light to what someone might mean when they say, everything is wrong, I'm miserable, my life is falling apart. A couple more snippets of data. So among people with demoralization, 11% had severe depression compared to just 2% who didn't have demoralization. 49% were lonely compared to 17% without demoralization. 82% had death anxiety compared to just 40% without demoralization, just a couple more. PTSD, 44% had PTSD with demoralization compared to just 3% who did not have demoralization. And this result is this result. I share all of this because when someone feels broken, everything can just, again, I'm really trying to emphasize this, it can touch so many physical, emotional, spiritual domains. And it's really, I can't give you an SSRI for that. There's no clear talk therapy to help with that. I, as a physician, feel profoundly impotent to help that. So we need to think about different ways and more innovative ways to think about how to support our patients. Just one more statistic. Among people who were highly demoralized, 98% of them used avoidance and denial to cope with their pain, as opposed to 46% who weren't demoralized. So what can we do to help? I think a lot of physicians, nurses, and other clinicians are also burnt out and demoralized because you went to school for all these years and all you have is you have your ego to rest on, but if you really can't help someone who has complex suffering, what do? You can gaslight people, you can run away from people, you can harm yourself, and that's why physicians have it's a little bit of a sobering, sad kind of talk, but it gets happier, have the highest suicide rate of any profession currently. So pallium, the word palliate comes from the word pallium, which means to cloak and to hide. So many of the drugs that we use in medicine, like benzodiazepines, SSRIs, morphine, fentanyl, etc., are designed to numb you and to help you cope with your pain. Whereas these are really anesthetic interventions. And what I believe George and I really strongly believe in is that these plant medicines and fungi that we're using in these trials really make you feel something, right? They're the opposite. They kind of rip the Band-Aid off, sometimes kind of too quickly. And I think of these as aesthetic interventions. They're beautiful interventions. They're colorful. They're vivid. They're transcendental. For those of you who are familiar with the work of Oliver Sacks and are familiar with the book or the movie Awakenings with Robert De Niro and Robin Williams, back in the day, where was this? In the Bronx, Oliver Sacks gave people who were basically frozen in these wheelchairs, frozen in their bodies because of an encephalitis, L-DOPA. And all of a sudden they were able to play ball, they were able to dance, they were able to relive their lives. And this book, this movie really inspired me to approach George and approach others to say, can we do something like this using psilocybin? For those of you who remember this movie or remember this book, you know how it ends, so I'm going to go back to how it ends towards the end of this talk. So, 2 years ago, we got together and thought of making a different kind of trial for people surviving, people living with palliative care conditions, whether you have a year of life left or whether you have 50 years of life left. We brought together, again, the best of palliative care. So in our team, we used what we call gold standard palliative care, chaplains, social workers, psychologists, and nurses. We brought them all together to be part of a comprehensive team to support the care seeker, the patient going through these trials. So George talked a little bit about psychedelic psychotherapy. How it looks and how it's so novel is that it's combining a pharmacologic with a behavioral intervention. So there are two variables at play. And it's spiritually integrated. We recently submitted a paper about this trial to a journal, and one of the reviewers asked us in a kind of snooty and harsh way, what if the person's not spiritual? And the way we define spirituality is we are all spiritual beings, whether or not you believe in a higher power or not. If you are connected to yourself, you are connected to art. If you are connected to mushrooms, if you are connected to fungi, to nature, you are a spiritual person. And that's why anything that helps us seek meaning and purpose in life is a spiritual endeavor, and that's why we're calling this a spiritually integrated intervention. We're addressing total pain, again, all the confluence of suffering, and we're doing it across the lifespan. So this is a picture of what the dosing room looks like at Emory. And You can, oh, you can see there's George on the left. And you can actually watch the dosing on PBS. You can find it on the Emory website, or you could just search like PBS, Your Fantastic Mind Psychedelics, and you can watch this care seeker's experience. And the way we think about our model is we have the care seeker, the patient, we have our spiritual health clinician. Again, at least 1 out of 3 people report a transcendental, spiritual, or religious experience using psilocybin. So we wanted someone who actually had thousands of hours of training in this to be present for them, who actually really was qualified to be in the room to support our patients, as well as a licensed mental health clinician. I can speak anecdotally from what our mental health clinicians tell me, is that they have generally not been trained in helping people with transcendental, transpersonal, or spiritual issues that come up. So I think this triad model is a wonderful creation of our group and something that we're manualizing and will study further. A little bit about the structure of the study. So our participants had 3 preparatory sessions. That's about 6 to 8 hours of therapy with the spiritual health clinician and the mental health clinician prior to dosing. Again, 1 dosing session with 25 milligrams of pure psilocybin. Again, for those familiar with the mushroom, that's anywhere from 3.5 to 5 grams. And then 3 integration sessions where people are invited to talk about their experience and identify any insights, any emotional breakthroughs, any spiritual or transcendental experiences that they could then translate into cognitive, behavioral, and really somatic, bodily felt changes to their life. Again, we're looking at cancer patients. We're calling them survivors because anyone living with cancer is a survivor. Living with chronic pain and demoralization, who was expected to live for at least 6 months. We dosed 10 patients over, I think, 14 months, 5 of whom had incurable cancers and 5 of whom had curable cancers. Since this was a pilot, we're primarily looking at safety and not so much whether or not the treatment works. We just applied for a grant that's going to get discussed next week, so fingers crossed, we can do that study next. So we were looking at safety. We were hoping that none of our patients would die from mushrooms or go to the hospital from them. And so we were hoping to have no serious adverse events. We were hoping that people would show up. And we were hoping that people would find the intervention to be acceptable. And then we were looking at a bunch of exploratory outcomes. Were there any changes in hopelessness or helplessness, demoralization, any changes to pain, any changes to anxiety and depression, and any changes to global flourishing, the sense that you have such a sense of well-being that like your life has more meaning and purpose, and that you feel like your life is going in a different kind of upward trajectory, however that may look like. So looking at the demoralization scale, so we have day 0 on the left. Dosing is the third one, is the middle one, and then we're looking all the way out to 98 days after, so over 3 months. And you could see demoralization scores plummeted on average in our patients. And you can, if you see those bars, the single line string bar, that shows the variance or variability. So some people had dramatic shifts, and some people had less dramatic shifts. And that's fun to science, right? One day we'll be able to hopefully identify who are the people who are most likely to respond to mushrooms and who are the ones who may not respond or maybe require multiple dosings or higher doses. So there's so much to learn scientifically from this. Of note, just 2 points is considered to be meaningful clinically. So going from 18 to 5 is pretty wild. Regarding pain, none of our psychotherapy really addressed issues about pain or pain coping. A future study I hope to do is actually going to manualize pain-related psychotherapy, but just focusing on demoralization, people had, statistically significant drops in pain intensity and interference. Again, huge variance. So some people's pain dropped to 0, and everyone in this trial had moderate to severe pain when they walked through the door. Some people had no changes to their pain. Again, this is something that we'll study in the future. Drops in anxiety and depression. And also, changes in flourishing. So day 42 was several weeks after dosing, and day 98, again, is about 3 months. People went from an average of 2.8 out of 10 to 7 out of 10. And some people you could see had 10 out of 10 flourishing in their life. The sense that just because they had this one experience with this medicine and psychosocial and spiritual support around them, that their life had meaning and purpose, which I think is a part of a larger paradigm shift in how we think about the ways in which we practice medicine for people with chronic diseases. The model was well liked. People wanted more time than 8 hours. So for those of you who perhaps have tripped before, 8 hours is a long time to spend in a clinical room and to have at least 4 people watching over you. And that's something we have to be mindful of. Some of our patients took the capsule. The capsule is supposed to work within 20 minutes, and it kicked in 3 hours later. So we just thought the medicine wasn't going to work, and then all of a sudden, boom, right? They're meeting their 7th generation ancestor. And then it's hour 8, people want to go home. It's night, it's winter time, people have kids at home, and then they're like, we're not ready to go home. I'm going to skip to the next slide for a second just to give you a sense of something one of our patients said. I wasn't ready to leave at 5 o'clock, and she was dosed at 9 a.m. I could tell that in the dosing room, it was time to close things up. And when I went outside, I literally had to hug a tree before I got in the car. Like, my portal is wide open, and I can't get in the car right now. I just stood there holding the tree, just trying to get myself grounded enough to be able to get in the car to go home. So something the medical system has to really figure out is, if we are going to be dosing people in clinical environments, someone's sleeping there overnight, can you have the option to stay? These are things we'll figure out with the community over time. People wanted something that was nature-based. If there are any billionaires in the room, something I'm dreaming of is to build this igloo in like the botanical garden that you can kind of close up but then open up, and then have people walk through a garden or something beautiful, just stunning while you're still with the medicine. We don't have money for that right now. People had worse pain during the trial. So some people, their pain skyrocketed while with the medicine. And that's something we as a field really need to figure out. If you're, over time, if your pain is going to decrease, but in that moment, your pain is worse, should we be giving you morphine or oxycodone or Dilaudid to get you through the experience? And we have some data to show about that in the future. People also wanted better transitions post-trial. The trial ends, right? And then some people are still wide open, and some people's metaphysics have changed, and fundamental beliefs about the world have now changed. And as a physician, what am I supposed to do about that? Or as a spiritual health clinician or a psychologist? So it's only 30 minutes in. Okay, we have a few more minutes left. So some people ended up getting acquainted with Christian psychedelic communities, others with Jewish psychedelic communities, others are now in a process group at Emory using formal psychotherapy, and they get to actually now meet each other and support each other through their cancer journeys, and then there are also personal journeys and psychospiritual journeys. Last couple of slides. Unique considerations of giving psychedelics to people who are sick. So in psychiatry, people tend to study psychiatric constructs, depression, anxiety, PTSD. In geriatrics and palliative care, we get to think a little bit more broadly. I think anyone gets to, but we feel compelled to think about things like chronic pain, which has physical manifestations and also very much psychospiritual and somatic manifestations. Quality of life as an outcome, and of course demoralization. The NIH, the National Institutes of Health, that basically run the national agenda for what science looks like, just released a call for proposals. They are giving one research group $22 million to study psilocybin in people over the age of 65, and they are very curious about people over the age of 80. And Emory is going to apply for this with some other institutions. So, the government's hearing this, they're seeing this, and they're interested in this, and they're especially interested in this for older adults and people with chronic medical conditions. Yeah. So DSM is the Diagnostic and Statistical Manual of Disorders. Basically, it's I I hate to use this word, but I'll use it, kind of the Bible of psychiatry. And that determines what is a psychiatric construct and what isn't. So like chronic pain isn't technically psychiatric. However, people with depression oftentimes have chronic pain along with it. So there are all these other things, well-being, a sense of spiritual wholeness, having hope, pain. These are all constructs that are worth studying that I think psychedelics can very much help with, that aren't necessarily exclusively in the domain of psychiatry. This has been really fun for us. This has been community building for us. I just spoke with a nurse who's in the audience who's interested in this work. I think I think any of you who've seen a doctor recently, I hope you've had great experiences. Maybe you haven't had some good experiences. I think doctors are really burnt out and tired. And I think nurses are burnt out and tired. COVID was really rough on a lot of people. And I think this kind of paradigm of healing people that really is, and I should have mentioned this earlier, inherited from the Mazatec tradition. Most of what we do, this triad model, the ways that we're giving the medicine, the eye shades to have people look inward, the music playlists, all comes from Mexico, and it's appropriated and really, I would say, adapted to the modern medical context, and also a kind of pluralistic American context where everyone's spiritual identity is respected. So it's been fun for us to learn from the Mazatecs, really, to create, I would say, hopefully the next version of how medicine helps people. Last couple points. Sorry, but the P's are really pronounced. For those of you, again, back to the story of awakenings. So these were people who woke up and life went back to normal, but for many of them, for most of them, after a couple of weeks and months, it wore off. Yeah, some people remember and are nodding, and they went back to, it kind of went back to black, things went back to gray. And I just saw one of our study patients a year after dosing who said, like, I was riding this wave for a whole year and she was just so much gratitude. And she's like, I'm starting to see the technicolors becoming black and white again. She just went to Mexico for a medicine ceremony using a different plant medicine. She didn't use a fungus. But something that we as a society, I think, can imagine is when someone is opened up that way, when someone does see the light, see spirits, see something beautiful or sacred within themselves, how can we as a community really rally and support that person to find ways, identify ways within themselves, within other human beings, within art, within nature, within mushrooms, within a power greater than themselves to feel that light, that once it starts to wear off. I think the modern medical framework is just give people more drugs, and it just can't be like give you more psilocybin. That would be, that's going to be the end of this movement, and then it's going to be outlawed again. So how can we as a society allow the mushrooms to evolve us to better support each other? And this is our wonderful team who worked on the study. This is just 10 patients, but it took a whole freaking village to do this work over 2 years. Almost no one got paid. George didn't get paid. I didn't get paid. So people woke up at 4 a.m, did their regular day job, and then went and did this work because of a belief that this can really help people. I hope we actually get money in the future so people can get paid. But I have a lot of gratitude and love for everyone who's part of this, and I hope we keep this going. So thank you so much. Okay, questions? Yeah, so the question is, are we looking at different strains of mushroom? So we're not even near that because we're all using synthetic psilocybin. So although I said the spirit is in the molecule, we're giving people a molecule. There's someone in Scottsdale, Arizona. Her name is Sue Sisley. She became kind of a legend a few years ago because she sued the government, because the federal government, because she wasn't allowed to research cannabis. And she didn't win. They kind of tossed the suit and allowed her to do her work. But right now, with her notoriety, she's creating capsules out of actual Psilocybe cubensis. So thinking about things like, yeah, I'm not going to name all the strains, but many of us know that different strains have different effects. And some people believe that's just the ratio of psilocybin to other components in it. We don't really know exactly why some strains feel a little bit different. I think that might be several decades away, unless there's a gigantic cultural shift and more people study this. Yeah. In the back. Demoralization. Did you just say a physical negativity? Yeah, so to clarify what I mean by demoralization is anyone can have demoralization syndrome. I think just like being alive in 2024, like I'm a doom scroller, and like after a certain amount of time on Twitter, I feel demoralized, transiently, thankfully. But demoralization became a more scientific, or I would say more well-studied construct, because so many medically ill people feel hopeless and miserable, and they don't, and when they would get interviewed to see if they had a psychiatric condition, they didn't fit into any square box. But I mean, certainly chronic pain, physical conditions, substance use disorders, any of those populations can have demoralization. You and then you. Oh, so we are not studying dementia patients right now. There is one group studying dementia patients at Johns Hopkins. It's a small pilot study. I know their results, and I don't think it's safe. It's just okay for me to share it. But probably in the next 2 or 3 years, those results will come out. And when I mentioned the NIH wants to give over $20 million to recruit older adults, they, for the first half of the grant, do not want anyone with dementia in it, because the NIH does not think that they're the population who would benefit the most from psychedelics.
I was going to ask you about another word that you were mentioning, spiritualization. You were talking about
Mm.
brand. That's a really tricky word in my mind. But one of the things I was thinking about was, have you ever experienced a patient that has talked about feeling nothing and everything at the same time? Feeling like they were nothing and feeling like they were everything?
Yeah. So there were I think two things there. One was the very word itself, spirituality, and then the other is feeling.
Well, it's connected is why I brought it up. I'm wondering if that might be a definition of what
Oh, connectedness. Oh, a spiritual experience. Well, a spiritual experience is however you want to define it. So we have a series of questionnaires that were designed in the 60s, one of which is the Mystical Experience Questionnaire that asks about feelings of being nothing and everything, as you just said it, among many other domains. The issue of a mystical experience or a spiritual experience is one I somewhat lazily defer to theologians. That being said, Buddhist traditions really did influenced the ways in which scientists thought in the 60s that ended up creating the questionnaires that we currently use. That being said, we're doing quite a bit of detailed qualitative work trying to ask people what they felt to begin with without putting words in their mouth. Like, you had a spiritual experience, or you had a noetic experience, or one of oneness, or sacredness, or whatever. So something that, I don't know if George alluded to it earlier, is we don't really give anyone a vocabulary about what their experience is. We're trained to mirror their vocabulary, however that may reveal itself, because the last thing we want to do is to start proselytizing, brainwashing, and converting people to whatever our own personal metaphysics is. Sure. Oh yeah, most of our patients had flashbacks to other, either their own experiences or previous, however you want to, whatever word you want to use. I'm going to say previous lives. Yep.
I was not quite clear when you were talking about protocols and the time before the psilocybin
Oh yeah.
administration, and then afterwards. Are those simply informational conversations, or are they therapeutic type? Are you trying to, provide some kind of therapeutic information in advance of the dosing session, or are you just saying, how do you feel? What's your mental state? Tell us where your marks are.
That's a great question. So the question is, what kind of therapy are we doing? So, yeah, I mean, the big question is, what is therapy? I would say what was done fits within the common factors of psychotherapy, meaning that there's rapport building, relationship building, psychoeducation on the ritual that we were about to do, a fundamental belief among all parties in this triad model that there was a ritual that was going to be done that would result in some sort of outcome, whether it would be personally felt healing or something else. This came from the USONA manual for depression, so it was informed by that manual. That being said, it's not a formal manualized therapy such as like cognitive behavioral therapy or ACT or whatever manual it is. What was actually done in the room was life review, exploration of the person's experience of cancer, experience of demoralization and hopelessness, some education around what the psilocybin experience might feel like, grounding techniques including breath work to help them stay grounded in case they felt like they were having an out-of-body experience that did not feel safe. Navigation and negotiation about touch. So if there would be touch, what would be the verbal and averbal signals that the participant would give the spiritual health clinician or therapist about whether they desire touch, and then where that touch could happen. So that was most of the preparation. So I would call that therapy, although it isn't. There weren't any homework assignments in between that were cognitive or behavioral in nature. And then the integration was very similar. By the third session, there was some sort of plan for going forward. So based on this entire experience you've had with us over 42 days, what will you take away from this? And then currently they're doing acceptance and commitment therapy at Emory. The people who graduated from this trial are doing acceptance and commitment therapy. It's called ACT. With 2 physicians. Not everyone is doing it. It's not part of the study, but like I mentioned, people wanted something more after the study was done, so we're giving them what they wanted. Yep.
I was curious if there were other types of, I think you mentioned negative experiences, and then also that there was some increasing body pain during the
Yeah, so George mentioned earlier, again, like, why is it at Emory? How did this happen? But like, we're becoming a center for describing adverse events in psychedelic trials. We've developed an entire, I'm going to answer your question, just giving a little advertisement for Emory. We just had a paper accepted for publication that is a suggestion to the community for how we can think about documenting things that may be perceived to be negative as a result of that experience. So there were no serious events in our trial. No one was hospitalized. No one died. the most common things that people had were transient anxiety during dosing, and we do know from prior just brief anxiety. And we know from prior trials that brief anxiety is actually is correlated with more durable benefit over time. So we're characterizing it as an adverse event because if someone coughs or even someone says, "I feel great," we have to write that as an adverse event. Though if it's brief and it's within those first 3 hours, the likelihood that it's going to help you is quite good. What else? Headaches. Typically, our patients would say that, not typically, but several patients said, at hour 7 or 8, like, oh, I really feel like I just ran a marathon. And that's an adverse event too, feelings of exhaustion at the end of the day. There was nothing that was persistent in our trial. And again, pain decreased over time for almost all of our patients. That being said, many of them had acute worsening of pain. And something we don't know yet is like, if you want to treat someone for pain, do you want them to have worse pain the first couple hours? Is there a lesson to be learned from that? In my head, with our very first patient, so our very first patient who said, "I'm in a lot of pain," I did not want to give her pain medicine. I was like, she needs to work through that. Like, and in my mind, it was like, this is a mother issue. Like, she has to go through it. And I felt like I punished her. And then the therapists eventually were like, this isn't working. Like, she's not getting through this. So in the end, we gave her medicine, her home medicine, and then she was able to keep going through the experience. But a consequence of that was some degree of rupture with me. And the relationship was strained because I really wanted her to suffer a little bit with the hope that she would, in the end, have a more durable benefit in terms of pain, which did not end up happening. You and then you. Yeah, we're not there yet, but that's a great idea. There are so many, I think just email us ideas. Just adding adjuvant fungi to the capsule itself. I think yeah. We're not even in a state where we can even give people mushrooms, right? We're giving people lab-made capsules. So, yeah. So I think kind of the next stage would be using actual mushroom, not next stage, down the road. You could even do a head-to-head, give someone a capsule or just grind the mushroom itself and put it in a capsule and see, is there any kind of phenomenological difference? And then think of more adjuvants. That's probably, many years away. Yeah. Even the idea of psychotherapy combined with, or talking to people about their feelings when giving them these capsules is still controversial. So the idea of giving someone lion's mane, like right after is, yeah. 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 Yes. At University of Wisconsin-Madison, there's a pharmacology group that's exploring some of this. In Scottsdale, Arizona, people are exploring some of this, but for that to actually be like part of something we do for humans is not there yet. Yeah. but it shouldn't be that far out. We'll get there soon. Yep.
So it sounds to me like you guys feel a little bit back into a corner around this adverse responses, while medical field out there rampant adverse responses. If they're experiments on our bodies, you know, they just give you this pill and tell you, oh, you're still alive, and follow the pill. So I'm curious, do you see a light at the tunnel when you guys are going to be allowed to let loose and really do some experiments and find what they say is really good for us in the long term? Or is it just, slow, larger?
So as George said before, one of our, if not the main focus, is safety. So I don't think of recording adverse events as necessarily a bad thing in our trials. It's just recording all the things that people can experience. So we just ask people, how did it make you feel? And I don't know what letting wild or can you explain what you meant by that? Because I feel like this is wild enough for medicine. Well, you're preaching to the choir, I get it, but it didn't work for her, right? So we would, yeah. And at the same time, you don't want to alienate people to then never come back again, right? So, and this is a delicate population. If you like search, if you go on Google or whatever your search engine is and look up psychotherapy for the dying, there's this transcript from the 50s or 60s of the psychotherapist with this woman with advanced cancer, and she had all of this pain, and he wouldn't give her pain medicine. And in the end, it was like something relationship that she had with an ancestor that then came to light, and then all her pain went away. And right, so that's one story, and then there's another story too. That's her. So there's. I don't know if there's any way for any of us to know what the right way to do this would be. Yeah, but she also might have just disappeared, never shown up, and complained, and got us all fired too if we didn't give her the pain medicine. You never know. Science. Preach. I get it. Yeah. I wouldn't say it's a mess. It's just it's hard to make things perfect when there are so many variables, and then there are humans involved, and then you have a palliative care population on top of that, right? So we want to be especially sensitive. Okay, you. Yeah, you first.
Outside of what we're talking about here, are there any studies being done on things such as ADHD and autism?
I don't know anything about ADHD studies. There is a young guy so there are people with autism who are enrolled in these studies, but the indication isn't for autism. And one guy, like 2 weeks ago, just wrote a book about it. If you just I forgot, if anyone knows his name, just say it louder. Yeah. Yeah. I listened to a bunch of his podcasts. They were really great. It's one person, maybe trials will come out of this. I don't even remember the name of the podcast. Say it louder. The book. Autism on Acid. Autism on Acid. He's very erudite, thoughtful, brilliant, all the things. There's no one on our team is thinking about microdosing right now. There was one study that came out a couple months ago. It was pretty well, or maybe a year ago, pretty well designed, where people created their own capsules, one with placebo and one with psilocybin, or one with psilocybe extract, and everyone benefited. So the placebo group did well too, which is not to say that microdosing doesn't work. It's just suggestibility and the placebo effect and the power of the mind is extraordinary. So after reading that study, I'm going to stick to macrodosing. And you.
So based off the
That would correlate with what?
That would correlate with how effective Psilocybin was at reducing your depression, reducing your pain,
Oh, yeah, for sure. So, and this is consistent with other studies at other institutions. So the more of a sense of an emotional breakthrough, whether that had what they defined as like a spiritual flavor or just any kind of narrative story about their life flavor that didn't have anything more transcendent about it, the more durable the benefit. So just the more meaningful someone found it to be, the more benefit there was. But it wasn't like any one specific thing. There, Bodhi Dunlop, who co-leads our center with George, is a co-author on a paper looking at the emotional breakthrough inventory. I know you're pre-med, so if you look up emotional breakthrough inventory, people who score high on that, and you actually use like natural language processing combined with that one inventory, the sense that you really like tapped into something huge in your life, or something bigger than your life. That was most that had the strongest association with long-term sense of well-being. Mm-hmm.
follow up to that. Do you think any of the preparatory sessions aided in your ability to take in psilocybin?
Yeah, that's a big question, and that might be the last one too, because it's 3:59. So the only way to really study that is to have one arm of the study be minimal support. And the idea, even with healthy volunteers, is, to what degree is like giving too little support unethical? So you could have enhanced psychotherapy where you're getting like 20 preparatory sessions compared to, let's say, what we did now. But there's no clear way to scientifically answer to what degree did the therapeutic component help. And that's why FDA and all of these regulatory agencies scratch their heads about these trials, because it's not just about the drug, it's about the relationship and the psychotherapy as well. Thank you so much.